reduction of risk potential. This section is definitely a section that is neglected, okay? We just tend to, I don't think this is covered, or I don't know any program where this is covered by itself. It's usually embedded in other material. So, for example, insertion of different tubes, a lot of your diagnostic tests with the MRIs, with radioisotope use. For example, another major area are with the different masks. I just had a student who passed the test and said, Professor Riggs, I had so many masks. It was mask after mask after mask after mask. So please, when we get to that section, pay attention, because there are a lot more masks on the NCLEX from what I'm hearing. I never heard that before. All right, so let's start. You're going to see how we're going to go through the systems, and each system, you know, their diagnostic tests. So let's start with the gastric analysis. So with those conditions, with the gastric analysis, we're measuring the gastric secretion under fasting conditions. So they need to be NPO, minimum 8 hours. If we can do more, more. Okay, if they smoke, they need to stop smoking. Okay, so standard precaution. By the way, as I go through these diagnostic tests, you're going to see me tell you what type of precaution you take. That also tells you what type of PPEs you need to be donning. We already done PPEs, okay? So this is standard precaution. So you need your gloves, you need your gown, you need your mask, right? Standard precaution. So there's something we use called histamine. So histamine regulates the function of the gut, okay? Which causes acid. It causes you to make stomach acid. Okay, so you're given that, okay? That's done via the nasogastric tube. In other words, we're gonna make you have a heartburn. That's really what we're doing. We're causing a heartburn. So, and then we want to analyze that. Okay, so that will tell us, okay, the indication, the purpose is, are you at risk or have any gastric ulcers? Okay, so a little bit of teaching with this prior to this test. They should not only be NPO, but they should refrain from taking certain medication if they're already on those medication, okay? So for example, if they're on any type of antacids, they need to hold those drugs at least for 24 hours. Any anticholinergics, hold those drugs. No alcohol, no smoking, no H2, no PPIs. All of those drugs need to be held before a gastric analysis, okay? So now fluid analysis. So fluid, for example, if a patient has fluid in the lungs, okay, pleural fluid analysis. So we're gonna do something called a thoracentesis, right? We're going to aspirate and pull that fluid out. For a thoracentesis, there is a positioning question. So the best way to do a thoracentesis is to have the client at the edge of the bed leaning forward, okay, over the bedside table, so we can get a nice expansion C shape of the thoracic cavity. Okay, so we do that for a number of reasons: fluid, inflammation, infection. We may need sampling. So another type of fluid analysis is with the peritoneum, the abdominal cavity. Okay, that's called a paracentesis. Okay, so the thoracic cavity, paracentesis, the peritoneum. Okay. So with those, sometimes patients have conditions where they have excess fluid in their abdominal tissue in the interstitial section. So we aspirate, we pull that out. Nice large bore needle, there's risk for infection, okay, with those. Another area where we pull fluid frequently is from the spinal cavity, cerebrospinal fluid analysis. That's called a lumbar puncture. So there's a positioning question with the lumbar puncture as well. So with the lumbar puncture, we need the patient in what we call a C shape. So we want to knee chest them. So their knees need to come up to their chest, okay, literally, okay? So that when their knees come to their chest, their spine does a C curve, okay? And I need that C shape, okay? So we're taking a sample of that spinal fluid. There's a lot of teaching post a spinal tap. You don't ever want to do a spinal tap if there's increased intracranial pressure. Okay, and then post a spinal tap, you want that pressure dressing and you want them on their backs, putting pressure and make sure they're not leaking cerebrospinal fluid, okay? So keep those little things in mind. Now let's talk about some visual testing, visualization testing. So there are different cavities in the body that we want to see what's there. Sometimes we go in and we take a sample. Okay, so these are direct inspection of different body parts. So the prefix in front of the word scope tells you where you're visualizing. Endoscope, you're visualizing the gastrointestinal tract. Laparoscope is used for abdominal visualization. Arthroscope, we're talking the joints. Okay, so for example, a client has a laparoscopic cholecystectomy, that's in the abdominal cavity. Okay, so that tells you where. The prefix tells you where in the body I am. So we do those by inserting a scope, okay, directly into that body opening via surgical incisions. So some of these could be a bit uncomfortable. So sometimes physicians will use what we call a fiber optic instrument, as you can see in the bottom right. Okay, it makes it a little bit more comfortable. Some of these procedures may need local, some may need general anesthesia. Okay. So here, uses of visualization tests. So for a number of reasons, sometimes physicians are going in just to visualize, just to inspect, just to look. Sometimes they are able to take a sample. They need a sample, okay, for assessing. So some therapeutic measures, we want to maybe remove different type of polyps with the client. My computer is showing a low battery. My apologies. Okay. We should be good with that. Okay, so other times they're used to implant stuff, so it depends on the need of the client. This is a very nice picture to show you that endoscope, because a lot of you are visual. That's why I use a lot of pictures frequently, because of the visual component. I'm like that too. All right, nursing intervention for whenever you're doing a visualization test, okay? These are invasive. So whenever you're doing anything invasive, you need a consent, okay? So don't forget that. You are never going to do these without the consent. You could get sued, okay? Second priority, you need to check for any type of dentures, okay? So we want to remove any type of dentures before the procedure, okay? Especially if you're going orally. Make sure they're NPO. The reason is to prevent aspiration, okay? And we give a lot of pre-op teaching and orders prior to these tests, okay? For example, after a bronchoscopy, there's a lot of teaching post a bronchoscopy. So bronch tells you I'm going via the bronchial tree, right through the bronchial tree. Again, the prefix tells you where you are. Oscopy, you're visualizing. So post a bronchoscopy, they could lose their voice or be very hoarse for a good 2 to 3 days. The other priority post a bronchoscopy is to watch the patient for laryngospasm. The airway could shut down. Okay, bronchospasm. So the first 24 hours post a bronchoscopy is crucial. The other thing you're going to do a couple hours after these procedures is to check the gag reflex. Literally take a tongue blade and stick it down their throat. They should gag if they have sensation. Because remember, as we go down the bronchial tree for bronchoscopy, we numb. Literally, we paralyze, we numb the passageway. So you also numb the epiglottis. So if you numb the epiglottis, you need to check. Priority post a bronchoscopy is to check that gag reflex to make sure that the sensation to the epiglottis is back. Because remember, the job of the epiglottis is to cover the trachea every time you swallow so you don't aspirate, okay? So it is priority to check that. So if you stick that, when you stick that tongue blade down their throat and they gag, you know the sensation to the epiglottis is back and you can feed them. If they don't gag, then that means they can't feel you doing that. That means the sensation is not back. Do not feed them, okay? NCLEX priority, and it makes sense. Arthroscopy is via the joint, okay? So post an arthroscopy, we want to always put ice to that joint, okay? And then we also need to tell the client they don't want to go and do any type of excessive exercise using that joint. For a good 2 to 3 days, you need to heal post something like that, okay? We're using, obviously, here in the picture, there's a large bore needle, okay? So avoid some weight bearing to that joint until you heal. Okay, whenever you do procedures laparoscopically, so again, I went over that earlier, laparoscopic, you talking about the abdominal cavity. So there's usually CO2, like you see here in the bottom right in the picture, there's usually CO2 that's instilled, that is put into your abdominal cavity. Priority post, for example, Mrs. Jones just came back from a laparoscopic cholecystectomy. She just had her gallbladder removed, but the way it was removed matters. She had it removed laparoscopically. So if she had her gallbladder removed laparoscopically, she needs to be passing gas post the procedure. So ask Mrs. Jones, are you having flatulence? Are you passing gas? Are you farting? If we want to talk layman's term, right? If she's not, I need her to start ambulating. Once you start ambulating, you're going to be passing that gas. If she's not, that gas, that CO2 that she was instilled with while they were doing the procedure laparoscopically is going to radiate and cause a lot of pain. So priority post a laparoscopic procedure is to be passing gas. Have them walk, trust me, that ambulation will get that gas moving, okay? So you'll be fine with those. All right, x-rays. X-rays are non-invasive, okay? Hence why we don't need an extra consent. They're not invasive. These are tests that use radiation. The radiation is the big deal with the x-ray, okay? So radiation is passed through that body cavity in order to paint that picture for you, right? So nursing intervention, priority with x-rays whenever you're doing these is to protect from that exposure to the radiation, okay? We want to always protect clients' genitals, okay? Drape them, that heavy, right, drape. And if a woman is ever pregnant, you're not doing an x-ray, okay, during pregnancy, because the exposure to the radiation, it's a small risk, okay? Research shows, study shows, is a small risk, but we don't want any risks to an unborn baby. Okay, but the risk is not major. Okay, but a consent is not needed for an x-ray. It is not invasive, okay? Now, so you'll see me point whether it's invasive, not invasive throughout, okay? Whenever it's invasive, you're gonna need a consent. Radiographs. Radiographs are a type of x-ray. So with radiographs, we use small doses of ionizing radiation. So hence the problem, okay, radiation. So same analogy before, okay, so radiograph is another type of x-ray. Radiation is used, a small amount, but you're still using radiation, okay? So before the test, make them NPO. We don't ever wanna risk aspiration. We also wanna clean their GI tract. So physicians will usually order magnesium citrate or go lightly. Go lightly, you don't go lightly. The name is so deceiving. They literally sit on the toilet and go. So some physician may order a suppository or an enema prior to a radiograph. It's a preference with this one. Some physician will just have them be in a low residue diet or clear liquid diet for 2 days prior to, okay, and make them NPO after that. And some physicians want them cleaned out. All right, after the procedure, whenever we use a barium with any type of procedure, so pay attention. If the physician orders a barium enema for this client, priority with the use of a barium is to pass the barium, okay? So I need to assess this client post a procedure that uses a barium enema and see that they had a white clay-colored stool, NCLEX. Post any procedure that uses a barium, I need to see the white clay-colored stool within 24 hours, okay? Even post the procedure, if they can take stuff by mouth, I'm encouraging them to drink a lot of fluid. I'm increasing that IV. I'm giving a Colace. I need to get that barium out of them, okay? So encourage drinking of more fluid to aid in the elimination of any barium that is used. Because what happens is you need to know the why. Why do we care that they pass the barium? Barium hardens. If it stays in this patient's GI tract for more than 24 hours, it turns into a rock. And imagine something turning into a rock inside your gastrointestinal system. It's gonna perforate it, okay? And that could kill you, okay? So we're gonna give fluid, laxative, everything. We want that barium out. And the way you know it's out is by seeing that white clay-colored stool. You'll be fine with that question. All right, next diagnostic test, CT scans. computerized tomographies. So they use x-rays and they use radiation to make that image. So you know what to do the moment, you know, radiation. I want to make sure you're not pregnant and all of that, right? So they should be NPO just like before, nothing changed. You're checking for pregnancy, nothing changed, okay? Tell the client to stay still for this type of exam. Okay, if barium is used, so same thing like I said before, okay, if the physician's gonna use a barium, depending on the body part we wanna assess, all of that I just said before applies again. In addition to that, if they use a barium for previous study, okay, you don't wanna do a computerized tomography, a CT scan, right after the use of a barium. You want to wait at least a good 4 days between those two diagnostic tests, because the barium will obscure the image of the CT scan. So pay attention. Mrs. Jones, 2 days ago, had a radiograph study where the physician orders a barium enema, and today she's scheduled for a CT scan. I want to wait at least a good 4 days in between any test that use the barium prior to, or else your CT scan, you're wasting your time. Okay, your CT scan will not be fully visualized. All right, next one, radio isotope scan, okay, or nuclear scan, same thing. Okay, the names are used interchangeably, but they mean the same thing. Those use intravenous injections, okay, of radioactive dye. So NCLEX, otherwise allergic to the substance that is made to make that injection. The dye that is used to make this injection is usually made with the shellfish product, eggs. So if they're allergic, okay, to iodine itself, right, to shellfish, to eggs, they cannot do this test, okay, because you're going to cause more trouble. Okay, so we need to find another diagnostic test for them. By the way, as we go through these diagnostic tests, when we do the actual disease processes, you'll see how every disorder is diagnosed somehow. That is why this is a client needs category all by itself, is because there is not one disease, one disorder. If you take a few seconds now to think of any disorder, there is a way that it is diagnosed. We don't just poof it out of the air. No, some type of test was done, whether it be blood work, whether it be a radioisotope, whether it be an MRI, a CT scan, something was done to diagnose you with whatever it is. That's why this section is important. So now as you go through diseases, you need to ask yourself, what was used to diagnose this problem? And as we go through these, I'll point out some of the conditions that these are more prone, you know, to using for. So back to the radioisotope. I couldn't help it. I had to point that out to you. So intravenous injection is used. So allergy is priority. I want to make sure you're not allergic to the substance I'm going to put in your veins. Right? That is crazy. So check for allergies, a priority. And the other thing with these, before you use them on a patient, for example, for renal or thyroid scan, I want to check to make sure that, you know, they can excrete this stuff. Okay, so check for renal function, because you put it in, how's it going to get out? Okay, we don't ever want to do more than one of these a day. Okay. NCLEX question. So you have a client who has gone for a radioisotope with intravenous injection, right? You, the healthcare provider, need to also be careful to not come in contact with this client's excretion, their urine, okay? Right here. For renal or thyroid scan, client may excrete radionucleotide after the test. So pregnant caregiver, so if you're a pregnant nurse, okay, or you're a pregnant person caring for this client, you should not handle their urine. Give them at least 24 hours of excreting this before you come in contact with their urine, okay? And if you're a woman who's postpartum and you're lactating, you're breastfeeding, and you have to go through a process like this, you want to excrete that milk post a radioisotope, clear that milk, pump it out, and throw it away before you give it to this child. And that has happened. I have a friend who, right after she had her third daughter, was diagnosed with breast cancer and needed to get on chemo and stuff right away. So she had to breastfeed. So sometimes these conditions happen. Okay, so there are some things that affect the result of these tests. If you have a diet high in iodine, okay, I need to know that. I need to assess that, because then my results are not going to be the real thing. If you are on anti-thyroid medications, okay, if you're on anything that's high in iodine, I need to assess that for a radioisotope scan. Okay. All right. So nursing intervention for all diagnostic tests that uses a contrast. Okay, so all of them. Number one, I'm going to check for hypersensitivity, because if you're allergic to it, I have a problem. Number two, I'm going to force fluid post. Okay, I need to get it out of you. Number three, don't forget to get a consent. Number four, I'm going to do a BUN and a creatinine, because what goes in needs to come out. And I'm also going to assess, especially if you're diabetic, your diabetics are special. Okay, whenever you're reading a question, it's a diabetic or a glaucoma client, those are special clients. They really just are. And they're special when it comes to medication. They're very difficult to treat when it comes to medication. And a lot of medications are contraindicated with these conditions. So if you're a diabetic, I want to do a medication reconciliation and make sure you're not on metformin. Okay, so metformin is commonly held before and after these exams, okay, with contrast because of renal failure. Okay, so do an assessment, make sure they're not on metformin if you're going to do anything with a contrast with them. NCLEX question, okay, what do you need to intervene? My metformin. All right. Okay, our next diagnostic test, ultrasounds. Okay, what is so special about the ultrasounds? Not much. We need a full bladder, okay, especially if you're wanting to see a fetal growth and everything. So bladder, full bladder, have them drink a lot of water prior to and hold, Kegel and hold that water in. I need a full bladder. But other than that, not a big deal with those, okay? EKG. So EKG, I'm just going to talk about a simple normal EKG here as a diagnostic test. We will break down EKG and go over abnormal, normal, and then an abnormal EKG when we do cardio, okay? So right now, this is not the breakdown of all your VFib, VTAC, and all of that. Not right here. This is just the diagnostic component of it. So EKG, you're looking at the electroactivity, okay, of the cardiac muscle. So electrocardiogram, sometimes you'll see written as an EKG or ECG, same thing. We're going to record the electromechanical activities of the myocardium, the muscle of the heart, the electricity firing of the heart. So we have a 12 lead that looks at the angle from 12 different angles, and then there's also one lead that's like a continuous. But in general, your EKG strip monitors 3 distinct waves. Okay, your P wave is your atrium contracting. Your QRS wave is your ventricles contracting. Your T wave is the relaxation of the ventricles. So those are the 3 main waves that are monitored and assessed with an EKG. We will break this down, okay, and talk about how long, each wave should take. What does it mean when it's prolonged? What disorder is that? We'll talk about VFib, VTAC, all of it, okay, when we do cardio. All right, so sometimes we do an exercise stress test, okay? So we are assessing the cardiac muscle while we stress it. So the client literally is on a treadmill, right? We're stressing the heart, and then we're looking at that EKG to see what they're doing. So just a little teaching with that. Prior to the test, don't overeat, okay? You shouldn't eat a good 2-3 hours before this test, because then we don't want you vomiting, okay? So sometimes we do a non-stress one where we utilize drugs to stress the heart. We're not physically stressing the heart. Okay, tell the client to bring comfortable clothes, because we're going to put them on a treadmill, comfortable shoes and stuff like that if we're doing the exercise stress test. So not a big deal with that one. EEG, electroencephalogram, okay, records electrical activity in the brain. It does not hurt, Okay, it is not invasive. There are a few teaching with this one. Okay, so if the patient is on seizure medications, anticonvulsant medications, tell them do not stop taking those medications unless you are ordered so by your physician. Continue your normal meds, your more anticonvulsants. We recommend that they get a good night's sleep before this test. Okay, tell them go to bed on time, sleep before this test. We need them to wash their hair before the test and after the test. And you can see why in the picture. If you have nice greasy hair, these are not going to stay. So wash your hair the night before and then wash your hair after the test. Okay, no caffeine before this test. Okay, so instruct them to eat meal prior to the test and avoid caffeine. You can have a normal breakfast, just no caffeine with this. Okay, MRIs. Magnetic, the name tells you. And I want you to get into the habit of actually saying the names of these acronyms, okay, instead of just saying the acronyms, because the names really tell you a lot. Read names. I've gotten really good at knowing prefixes and suffixes and meaning of words because I work on it and I've always been fascinated by it. So magnetic tells me there's magnets somewhere. Right? An MRI, magnetic resonance imaging, has huge magnets inside of them. This machine that you're looking at is surrounded by these huge magnets. What do magnets do? They pull metal. Okay? So one of the assessments for MRI of magnetic resonance imaging is to make sure the patient doesn't have metals in their body. Because if they have metals in their body, imagine that huge metal is going to pull that magnet. So if you have that lovely pacemaker, which is made of metal, an MRI is not for you. If you have that false hip that is made of metal, an MRI is not for you. Although we don't have time, I'm going to give you a quick example of how real this whole metal thing is. After I had Daniel, I had to have an MRI because I was preeclamptic, right? Blood pressure sky high, magnesium, the whole 9 yards. So I had to have an MRI post Daniel, and the young woman was scanning my head, and my head kept beeping. And I had safety pins, bobby pins, sorry, not safety pins, bobby pins all over my head because I like wearing bobby pins, right? So I took out all the bobby pins and my head still kept beeping. So I was like, I took them all out. There's nothing left in my head, but my head kept beeping. Long story short, it turns out my extensions, because I wear extensions, and they're sewn in my hair, literally. So those of you always complimenting me for my hair, thank you. They're not mine. Not all of it anyway. Some of it is. All right. So I have these extensions sewn in, right? The extensions have metals in them. Did you all know that? Like I learned that years ago when I had to have an MRI. So I called my sister who's a physician. I was like, did you know our extensions? Because she was extensions too. I said, do you know that they have metals in them? So I was telling her I can't do this MRI. So my other sister who does our hair had to come to the hospital and take out my extension so that I could get this MRI done because I couldn't get it done because of the stupid metals. So the metal thing is real, y'all. No metals anywhere, okay? So we want to assess for that, number one. Number two, you always want to assess for claustrophobia. This is another time when I found out that I was claustrophobic. So after all this whole metal in the hair thing, the young woman goes to push me into the closed MRI. I freaked out. It is the creepiest thing, y'all. It is as if you're being buried alive. I was like a cat going into water. I was like, no, can't do it. It's just the creepiest thing. I can't. I was like, no. So then the physician ordered a Xanax. I took the Xanax. I still couldn't do it. I was like, nope, Xanax didn't work. It really didn't work. I was like, nope, I know what you're doing. I can't go in that machine. Literally, it freaked me out. Okay, so I had to do an open MRI. I'm a big turkey. Terrible. Okay, my stories hopefully will help you get these NCLEX questions right. I wish I had more time to tell you more stories of other craziness throughout this review, but we're stressed for time. So check for metal, check for claustrophobia, okay? With an MRI, because the word magnet tells you a lot with the metal, and that includes hearing aids, okay? That includes removing the dental work and all of that. All right, biopsies. Nursing intervention for biopsies. So biopsies, we're taking a little piece of something somewhere, right? So there's risk for bleeding. So one of the priorities with the biopsies is that bleeding disorder, if they have a history of bleeding disorder, or they're on an antiplatelet, they're in an anticoagulant, which puts them at risk for bleeding, I would want to assess that and review that. And they may need to get off these drugs, for a little while before they can do certain procedures. So post the procedure, I want to monitor bleeding, okay, at least a good 2 to 3 days after. And I also want to monitor for infection a good 5 to 10 days after, depending on what it is that they had done. You see, for example, if the physician takes a biopsy of the thyroid, there's major risk here, or the liver. And don't forget, for some of these biopsies, there's a positioning. You always want to put pressure in that area in order to prevent hemorrhaging, okay, to prevent bleeding. Okay. In reference to the contrast question, yes. Okay. All right, perfect. I want to make sure you didn't have any other questions. All right, PPD, skin test, few skin tests. So your purified protein derivative, PPD, that is always done intradermally, okay? So you need to know the layers of the skin, and this one is done intradermally. Know the route for this. It's not sub-Q, it's not IM, it's intradermal, okay? Very small needle. So those we want to do if we know patient has been exposed to tuberculosis, okay? Now, we have to read those. They have a window. We have to read them within 48 to 72 hours. If you miss your window of the 2 to 3 days, you need to redo another one, okay? No exception to that. Now, positive reaction. The positive reaction, the number that you're going to use to determine whether this PPD is positive depends on whether you're dealing with a healthy or immunosuppressed client. I'm going to say that one more time. When you're reading and assessing a PPD, the way you determine whether this PPD is positive, you have a positive reaction, is to check and see, is your patient healthy or are they immunosuppressed? If they're healthy, okay, then 10 millimeters, meaning the induration, the elevated part, not the red area, that's not what you're measuring. You're not measuring the round that's red, you're measuring the elevated, the indurated section. If it's more than 10 millimeters in a healthy person, then that's positive. If it's an immunosuppressed, leukemia, chemo, HIV positive, those are all immunosuppressed clients, 5 millimeters. Okay, so one more time, don't miss this question. Immunosuppressed, 5 millimeters. Healthy, 10. Okay? I think. Okay, just want to make sure you don't have any questions. All right, so you're good with that. Now, the chest x-ray. The chest x-ray does not say you have TB. So keep that in mind. The only way you diagnose TB is with the sputums. 3 positive sputums, 3 separate mornings. The chest x-ray, we do that if you have a positive PPD. If you have a positive PPD, get the x-ray moving forward, okay? That's what we do from now on. Now we don't even recommend the chest x-ray anymore. If you don't have any signs and symptoms, that's good enough, but we got to stick with the book. For your NCLEX purposes, the x-ray just will show calcification, but it will not say you have TB. You could have, it could be positive old ones, and then yet you have no signs and symptoms, okay? But we need to diagnose TB with the PPD, okay? Now, ear and balancing, couple of questions with those. So these are the tests. You covered this such a long time ago, and some schools go over this so quickly. It's not a heavy material, but there's these tests we do for balance called Romberg test. And then there's a caloric one that we do as well. So with the Romberg, we literally have the client stand with their feet together, their eyes closed, okay, and put their hands out. We want to make sure there's no swaying, okay? So if there's any abnormality with the ear and the cochlea and all of that, they're going to have some swaying. So close your eyes, put your feet together, I want to monitor for that swaying. So the caloric test deals with you instilling water in the client's ear, okay? So cold versus warm water. So with the cold water, once you put it in the ear, the eye will deviate to it, like you see in the picture here, okay? If that doesn't happen, then there may be some neurological problems, okay? And then warm water, the eyes should move towards warm water when slowly move back. Okay, so if I see negative results for these, then I want to look into maybe they might have Meniere's disease or something like that. Not a heavy section either. Okay, so now your cranial nerves, you do need to memorize these. There's nothing I can do about that. You need little mnemonics, okay, to these to help you remember them. Okay. GI, there are a few. Let me go back. By the way, I throw a few of them at you, but there are others, and you could even make your own. Okay. GI. Let's go to some GI diagnostic tests. There's one called manometry test or manometer. So when we use those, we're assessing for movement and pressure, but with your esophagus, not so much your stomach yet. We usually do those with heartburn, okay, like with GERD. Okay, so your normal lower esophageal sphincter pressure should be 10 to 20 millimeters. Okay, so with these clients that have GERD or abnormality gastroesophageal reflux, it might be higher, okay? So we literally put the scope down, we measure the pressure. So if we want further assessment, we may do an esophageal reflux or AKA Bernstein test. You probably forgot about these tests again. I warned you about that from the beginning because we did them such a long time ago. And not only that, some schools neglect to even really do them in depth. So the Bernstein test is also called an acid perfusion test. So we use the hydrochloric acid via the nasogastric tube. You saw the nasogastric tube earlier. And then we put normal saline. So just like earlier I mentioned, we may sometimes cause a heartburn. Okay, I told you I was gonna talk about that. So that is what we're doing. And if the patient has that excess acid, then we know they're at risk for heartburn. So it could be, if it's positive, where they're very uncomfortable with that hydrochloric acid, then they may have esophagitis, itis inflammation of the esophagus. Or they could have ulcers, then they need further testing, okay? So for an esophageal reflux. All right, another type of test we do or procedure, paracentesis. I talked a little bit about thoracentesis earlier and different aspiration of fluid. So this one is a little bit more in depth why it's in this area. So we're gonna drain the abdominal fluid from these clients that have what we call ascites. So when you have liver failure, you're at risk of ascites. So the physician, by the way, do this. I need to also tell you, there's a lot of material where we don't do those skills, but we get questioned, LPNs as well, as if we do them. So you need to know, but there are some of them we'll never do. It's just not under our umbrella. RNs, for example, you're tested as if you do for example, arterial blood gas with the Allen's test. We don't do arterial blood gases, but you still need to know about the Allen's test, okay? So there are material where we need to know about it as if we perform it, but we don't perform it, okay? It's just the way it is. So don't think, oh, I don't do that, I don't need to know about it. That's not the case, sorry. That's just the way it is. So before we do paracentesis, we have the client void, okay? And then we want to always, when we remove the fluid, it's done over a very slow period of time. So between 30 to 90 minutes, half an hour to an hour and a half. And no more than 500 mLs, over 30 minutes. So there's a whole slow pace to this, okay? You don't want to do this thing quickly because then the fluid shift will be happening too quickly. So afterwards, we want to make sure they're not leaking fluid. If we're going to get specimen, we send it to the lab, but no more, not more of a big deal with this. It's just a removal of all that excess fluid from the abdominal cavity. Okay, now PFT, pulmonary function test, non-invasive, okay? The whole purpose of the pulmonary function test is to look for exchange. You have a patient breathing their normal breaths per hour, but are they exchanging? Are they giving off CO2 and picking up O2? Okay, so it utilizes a specific spirometer, like, you know, with the incentive spirometer, but this one uses a spirometer to record exchange of these two substances, O2 and CO2. So have the client sit upright. And again, this is another area with skills. There's a video on how to properly do this. And before the end of the review, I will deviate to show you where they are, okay? So we use these for a number of these diseases. A lot of respiratory lung diseases, you may need a PFT test, okay? So teach the client, clip the nose, okay, during the actual test. All right, thoracentesis, we briefly mentioned earlier. Let's go over the nursing intervention specifically for that. So you know there's a whole positioning question that I went over earlier. You should be good with that. The only extra nursing intervention that I want to mention here is you must do a chest x-ray post a thoracentesis, okay? Assess that because you could have nicked the client, collapsed a lung, okay? Your pulse ox, so we have the external way to monitor the oxygen level in the patient's blood via the pulse oximeter, okay? So we want at least 93% or better, but there are some things that you need to be aware of that could hinder a proper result from your pulse ox. So the lighting in the room, okay? Tremors, seizures, poor perfusion, even the nail polish on patients' nails could hinder you getting an actual result. So these are silly little things you need to read, nothing major, okay? Lumbar puncture, again, I mentioned the shape, the C spine shape. So obviously these are recap. I like to recap so it sticks in your long-term memory. Okay, so don't forget, keep the client lying on their backs because you don't want them leaking cerebrospinal fluid. Okay, we want to observe for that headache. They may have a headache afterwards. Okay, we want to assess the dressing, make sure it's not wet. There might be leaking cerebrospinal fluid. Okay, now ICP, increased intracranial pressure. So whenever we're doing a lumbar puncture, you want to always make sure that that is done under sterile technique so you don't end up causing an infection, which could cause ICP. So we always want to maintain sterile technique, you know, with a lumbar puncture and stuff like that. Especially if they're leaking cerebrospinal fluid, we want to make sure they don't catch an infection because that's going to in turn cause meningitis. So you have an infection in your cerebrospinal fluid, which is floating all over your central nervous system. That's a problem. You also need to memorize normal intracranial pressure. It's between 5 and 15. Okay, so add that to your list of stuff you need to memorize. Normal ICP, 5 to 15, okay, millimeters. All right, hemodynamic monitoring, okay? So hemodynamic monitoring is very invasive, okay? Hemo, you know, we're touching blood. So it's an invasive cardiac catheter. So we go in a large blood vessel, okay, and then we filter that catheter. The goal is to monitor the pressure in your heart. So the catheter is usually introduced into a large blood vessel, okay? And the purpose of it is to monitor the pressure in your heart, but very, very invasive. As you can see here in this picture, whenever you're accessing a large blood vessel, okay, there's so much risk, infection, hemorrhaging, perforation, okay? So, but that's a hemodynamic monitoring. So there's some nursing intervention for all of these procedures we just talked about. Some of them are done under surgical asepsis. Okay, some may be done under medical, but whenever you're being, you're touching blood or you're being invasive, it's sterile, okay? Whenever you're invasive, you need a consent, okay? So these are some repetition of some of what I've just mentioned, okay? Now, hemodialysis. So you have a patient whose glomerular filtration rate is less than 60 and they need hemodialysis. So we need to clean their blood for them externally. So they will need either a arteriovenous fistula, AV fistula, or an arteriovenous graft where we use their own vein, or they may need a central venous catheter, a catheter that goes right into a great vessel. Okay, so with AV fistula, we're using an artery and a vein and connecting them, okay, like you see in the picture here. So with hemodialysis, there's a lot of nursing intervention, some teaching, and some things to keep in mind. So with these type of procedures, we want to monitor or reinforce, okay, diet and some things that they need to be restricted from between treatments, okay? And we also want to always do their blood pressure prior to, and we may need to hold their antihypertensives, okay? There's a lot of complications with dialysis, okay? So we want to monitor for these complications. They could go into heart failure, stroke, infection. Obviously, you're accessing large blood vessels. There's always a risk for infection for these, okay? Now, peritoneal dialysis is very different from hemodialysis. So with peritoneal dialysis, you have an indwelling catheter, and indwelling, it stays there, okay? So there's an indwelling catheter that is permanently implanted in the layers in the peritoneum cavity of this patient's stomach, okay? So with this is not like a paracentesis you just saw us do where we pull out the fluid. No, this is a permanent catheter that stays in the patient. So what we do is we infuse them with the solution, okay? And we always do that via gravity. And those are huge bags of like 2 liters of substance in there that we instill via gravity. So after it's instilled via gravity, it stays in the patient's stomach based on what the physician orders, 4 to 6 hours. If it's nighttime, sometimes they go to sleep with it for 8 hours. And then we drain that fluid out again via gravity. So what goes in must come out. Keep that in mind. So if I'm instilling 2 liters, okay, 2,000 milliliters of fluid, I better get 2,000 milliliters of fluid out. Okay, so what goes in must come out, and you always want to assess that. Okay, make sure it's not, there's no infection, it's not cloudy, there's no blood, and things like that. So you have to keep that in mind. There's a couple of nursing interventions or follow-up or assessment you need to do post after the fluid comes out. So if the client is prone to infection, they may not be a candidate for continuous ambulatory peritoneal dialysis, which the whole thing with peritoneal dialysis, it gives you a little freedom, whereas hemodialysis does not give you a little freedom, okay? But peritoneal dialysis does, which is good, but if they're prone to infection, this is not a good thing for them. All right, pacemaker. So pacemakers, they keep your heart beating at a regular pace. Keep that in mind. They keep your heart beating at a regular pace. They don't jump start the heart. Okay, so remember, pacemakers are made out of metal. So we're back to the MRI story. Okay, so the magnetic field is an important teaching thing for this client. This client cannot do contact sports anymore because of this pacemaker. Okay, they should wear a medical alert bracelet. Okay. They may need the batteries replaced after so many years, okay? So post a procedure, they should rest for a good day or 2. Little things like that you can read, not a big deal. But don't mix a pacemaker, okay, which only keeps the heart beating regularly versus a AICD. A AICD is an automatic implanted cardioverter defibrillator. You're familiar with the AED, automated external defibrillator. So this is a device that is implanted in your chest, and its goal is to correct abnormal rhythm. Okay, very painful. So your heart goes into VFib, and if you have an AICD, it's going to correct that abnormal rhythm. Same analogy before, avoid the magnetic field because it's metal. Okay, assure the client that no household appliance will affect it. For example, you know how we tell them with the pacemaker, don't go near the microwave. That's not prevalent anymore. The car battery is still prevalent. They cannot go and lean over the battery of a car. Okay, so that is still prevalent. Also teach them if they need to get a shock from this, it's very painful. Okay, silly little things. All right, next category, endotracheal tubing. So some nursing interventions for your endotracheal tubings. If the patient has edentulous, toothless, okay, they don't have any teeth, we want to find a way to mark the tube, because that's one of the ways we mark it is with the teeth. So if they don't have that, we have to find another way to do it. So nursing intervention with the endotracheal. Suctioning is a big deal. We're going to go over suctioning with a patient with an endotracheal tube. And there are some complications with an endotracheal tube. Aspiration is one of the first complications. Right? There are some other ones with the skin, the mouth, some sores. Accidental extubation is also a concern, but aspiration is the biggest priority concern. So now, tracheostomy. So we're going to talk about some nursing intervention for them in general. So tracheostomy. So now, earlier we were talking about endotracheal. So this is going through the mouth into the trachea, whereas a tracheostomy, okay, you're making a hole right into the trachea. Very different, okay? Endo is via the mouth, okay, endotracheal. So they're going through the client's mouth into the trachea. Okay, as you get the risk of aspiration. And tracheostomy is a hole, ostomy is a hole right into the trachea. Okay, so you always want to auscultate lung sounds for these things. There's special care for the ostomy. We want to see nice granulation, you know, with these right after, but we don't want to hear stuff like foul smelling, pus, you know, excess exudate, stuff like that. So we're going to talk about suctioning technique with those. There's a lot of questions with those. So here's a little clip on the proper way to suction a tracheostomy. So don't forget a couple of things with these type of questions. Number one, there's skills questions. So I would encourage you to look at the videos again and again, because this is one of those drag and paste step 1, step 2, step 3. I want to remind you of a couple of things. Okay. So number one, when you're airway suctioning, that's always a sterile procedure. Okay. Imagine you're going into the lungs, right? Is always a sterile procedure, especially at the hospital setting. The suction control that you're using to suction the airway, maximum you ever want it to be is 120. 80 to 120 is your range. If you use more than 120, you're going to cause tissue damage. Okay, so always adjust your suction control to be below 120. More than that, you're doing damage. You always want to hyper oxygenate, because as you suction, you're pulling oxygen. So hyper oxygenate them. Okay, so don't turn the suction on until you're pulling out. That's another thing. And while you're pulling out, rotate. And this whole airway suctioning should take 10 seconds maximum. Okay, so those are the most important parts of this procedure, but this is something you need to look at again and again. Okay, so a couple other nursing interventions or reinforcement for this type of procedure. The positioning matters. Okay, if the client is able to, put them in a semi-Fowler. Okay, if their condition allows them, then put them in a high Fowler, but sometimes their condition doesn't allow them to do that. Okay, we don't routinely use saline. If you can use a humidifier, okay, to break down and loosen secretion, that's always better. Okay, we talked about hyper oxygenate. Never force the catheter in. Okay, you knew that. Now we're going to talk about different oxygen modality. So the first one is the nasal cannula. Okay, O2 delivery. So the nasal cannula, pay attention as to the maximum amount of oxygen these devices will give you and the maximum amount of liters as well. So nasal cannula maximum is going to give you 40% at a 6% liter per minute, right? So now the big deal with the nasal cannula, you need to know, who they're for. So clients with hypoxemia, not enough not enough oxygen, and with chronic hypercapnia, too much CO2. So low oxygen, too much CO2. These are a great device for them, aka COPD, okay? Or also best for your COPD client, okay? Maximum you want to do for a COPD client is 2 liters. We can remember COPD, they have a different mechanism. If you give them too much oxygen, they stop breathing, right? So you don't ever want to give them more than 2 liters, okay? So if you're nursing intervention with the nares, you want to make sure that it's not breaking down and behind the ears and stuff like that, but nothing major. You can just read this stuff. Your next mask is the simple face mask. What you need to remember about the simple face mask, maximum oxygen you're going to get is 60%, and you can go up to 12 liters per minute. But this one allows room air to enter the mask. So you're not getting 100% oxygen, okay? So keep that in mind. This is also for short-term use. Also, you can see she's not going to be able to eat with this, okay? So not a big deal with the simple mask. Venturi mask. So with the Venturi, 50% oxygen up to 15 liters per minute. So this one uses what we call an air entrainment principle to deliver the exact amount of oxygen you want. This is also good for your COPD client, okay? You could keep it on a low flow rate for your COPD client. Again, you would need to remove this when it's time to eat and put a nasal cannula, because obviously you cannot eat with this one. Okay, but this one you can give the precise amount of oxygen that you want. But also make sure that the adapter is open. Okay, so keep that air entrapment port for the Venturi on the side of it, keep that open and uncovered so that you can make sure the client is getting the adequate amount of oxygen. And by the way, all of these oxygen modalities, the face mask, they dry your mucous membrane. Okay, so these patients need to stay hydrated. Okay, your non-rebreather is special. So your non-rebreather has that extra reservoir, the bag, you can see that, has that added reservoir bag, and it also has what we call a one-way valve. Okay, so when the patient breathes out, it doesn't go into the bag for them to rebreathe that air back. So it prevents client from exhaling back into the bag because it has that one-way valve. Okay, and then that room air, like you see in the face mask, doesn't come back into this. The patient doesn't breathe that back. So this one has a very high, no other mask give you a greater percent of oxygen than a non-rebreather. Okay, so you would never put a non-rebreather on a COPD client, never, never. So a non-rebreather provides the highest percent of oxygen available from any mask. Okay, they are reserved for critically ill client. Okay, so if you have a critically ill, severely ill client, you need them to get 100% oxygen. A non-rebreather mask is for them. Okay, so we use these for the sickest client. They have that reservoir bag that also makes sure your nursing intervention, that bag can never completely be collapsed. So ensure that reservoir bag does not completely collapse during inspiration. So they breathe in. If that bag collapses all the way in, you're defeating the purpose. Okay, so keep that in mind. All right, BiPAPs and CPAPs. What's the big difference between BiPAPs and CPAP? So the names, again, that's why I want you to get used to the full names instead of these abbreviated names. BiPAP stands for bi-level. Bi means two. Bi-level positive air pressure. Whereas CPAP stands for continuous positive airway pressure. So BiPAP, the word bi means it has two pressure settings. That's the big difference. There's two pressure settings. Both of them are non-invasive, okay? We're not puncturing anything, entering inner cavity. Nope, both of them are non-invasive. But BiPAP has two pressure settings, whereas CPAP has a continuous ongoing setting. Okay, so we use these a lot for patients with sleep apnea. Would be better on a CPAP, on a continuous positive airway pressure, so that when the patient breathes in, their normal air inhalation activates it, but when they breathe out, the CPAP helps them to continue to breathe out and blow off CO2. That is what these devices do. Okay, so great for clients who trap in CO2. That way we can help them exhale that CO2 while they sleep. Okay. Ventilators. So ventilators, there are a couple of NCLEX questions on ventilators that deal with the alarms on the vent. Okay, so you know when a patient can't breathe on their own, they may need to be put on a ventilator in order for us to have that mechanical. So where the machine is breathing for them, right? So that mechanical breathing is done by the ventilator. So now we can set the ventilator to different settings. We can set the ventilator to act as a BiPAP or CPAP. But there are these questions about the alarms on your ventilators, okay? Because it's our job to make sure they're working properly. So you have a high pressure alarm. Usually the high pressure alarm goes off when there's an obstruction. The client is biting on it, okay? The client has too much secretion, okay? Or maybe the tube is slipping into the tissue, a number of reasons. That's your high pressure, usually for an obstruction. Your low pressure alarm goes off when there's a leak. So you may need to find where that leak is for your ventilators, okay? There aren't too many questions on, you know, setting up the setting and everything for a ventilator, because that's up to the physician and it's based on the client needs, okay? So your alarms are your questions with your ventilators. All right, chest physiotherapy. You need to be familiar with, especially you have a cystic fibrosis client or someone like that where they have all that excess secretion that we need to loosen up and get them to get rid of it. Okay, so we may need to use bronchodilators and mucolytics to open the airway and loosen the mucus, or if they have edema, we may need to use some steroids. But there's questions about the chest physiotherapy itself. You see how this woman's hand in the picture are very coughed up, okay? So you want to cup your hand like that for the physiotherapy, and obviously you're changing them position. There's 10 different body positions that are used with chest physiotherapy, and gravity is also a thing with chest physiotherapy. It makes sense, okay? So you can get all that mucus out for these children. All right, chest drainage tube, so your chest tube. So a couple of things with your chest tube. So with the chest tube, you have 3 different chambers with the chest tube. So you need to pay attention as to which chamber they're dealing with, because the fluctuation in fluid in the chest tube depends on which chamber, and it depends on the patient's breathing, coughing, or what the patient is doing. But just in general, we don't milk or strip chest tubes anymore. Okay, we don't routinely clamp chest tubes anymore. These are old practice, and you need to be familiar in the fact that we don't do those anymore. So the patient may need a chest tube for a number of reasons. Air puncture, fluid in the lungs, collapsed lung, a number of reasons why they may need a chest tube. Okay, so there's NCLEX question on the tube dislodging. For these questions on the NCLEX with the dislodged tube, pay attention whether the tube is coming out of the patient or out of the device, because it matters, okay? So if the tube is coming out of the client, out of the chest of this patient, you need that occlusive dressing. Okay, you need to apply that Vaseline gauze, which is your occlusive dressing. So that occlusive dressing, that Vaseline gauze, will cover the hole, because you don't want atmospheric air going into the patient's lung. Then you're going to get what we call a tension pneumothorax, where the trachea, the heart, the lungs, everything is moved to the other side. You don't want that. A tension pneumothorax is always a medical emergency, okay? So you want to always have that at the bedside. That's 1. 2, if it's coming out of the device, you want to have a hemostat at the bedside. It's those scissors that clamp, and you want to have a bottle of normal saline at the bedside to put the tube in. Okay, so it comes out of the patient, you need the occlusive dressing, and you know you want to tape it in 3 areas and leave that open area, okay? We'll cover chest tube again just to reinforce it when we do respiratory, because there are a few more questions on this area, but this is just the diagnose part of it. Your urinary drainage bag, so the patient is on an indwelling Foley catheter. You know, I mentioned it earlier, never lift the bag above the symphysis pubis, because you end up causing an infection, okay? Also, we wanna empty this bag as needed, but whenever it's a half, a 3/3 full, we wanna empty it, okay? If the patient's putting out a lot more fluid, or at the end of every shift, if they're not putting out a lot. Okay, we always want to encourage, if their diet allows it, a lot of fluid intake to flush that urethra, but you also want to assess, make sure it's not cloudy, silly things like that, you already know. Wound drainage. So sometimes a patient will have a closed drain, sometimes they'll have an open drain. Your closed drains are more like your Jackson Prats, like you can see here in this picture, they're closed drain. So you know with the Jackson Prats, we want to squeeze them in as they inflate back, they pull out that fluid. So we empty them when they're a third or half full. You don't want it being more full than that. Pay attention to the type of fluid that comes out. It depends on the many days post-op. If it's the first day, you expect sanguineous, that's blood. Okay, about 3 days later, you expect what we call serous sanguineous. After that, serious blood fluid. So pay attention how many days post-procedure they are. So sometimes we have open drains, like you see here in the bottom picture. There's nothing closing it. The fluid will just come out. So these clients, we may need to do frequent dressing changes. You want to wear sterile gloves when you deal with these, obviously. Some physician will order what you call a Penrose. Okay, those are sterile, like they'll order a new one to be put on these. So it's a preference with this one. Okay, but know that there's closed versus open. So there's also dressings, compressors, bandages, irrigation. The other thing I want to mention with these type of tests and procedures, PPEs. So the PPE you put on depends on what you're doing. If you're doing like a wet to dry, you may not need goggles. But if you're irrigating, you need goggles, right? So think about the PPEs as you do these dressing changes or these skills, okay? So these are just some nursing intervention for these. These are not heavy stuff. You can go over how to band-aid, the sling. Those are nothing heavy. Irrigation is another one you want to glimpse at. They're not heavy stuff. How to irrigate the ear, even irrigating the bladder, nothing heavy. There's so many different areas you would need to irrigate, nothing heavy. All right, the cast. I want to mention something with the cast. So the cast, you have a patient with a fracture. There are different types of casts we put on because there are different types of fractures. Could be long bone, short bone, leg, spine. Oh, we could go on and on, right? So with the cast, there's plaster, or also called plaster of Paris cast. Those are the ones that look like clay. They go on wet, right? NCLEX. Never touch a plaster, cast or cast period that you just put on with the tip of your fingers. Why? And NCLEX asks why. Because you could cause a little something we call indentation. If you cause indentation, you're putting pressure in an area and it dries that way. If it dries with that pressure you put on because you touched it with the tip of your fingers instead of the palm of your hand, you stop circulation. It dries that way, putting pressure in that area, which decreases blood flow to the rest of this extremity. So after this dries, you always want to do a neurovascular check. Touch the patient, make sure they're not feeling any numbness, tingling, are they warm to touch? You always want to do a neurovascular check, okay? Have them open and close the arm, depending on the type of cast they have. Also, allow air dry. We don't force these. And once it dries, teach them not to stick anything in there, right? The blow dryer is a great way to prevent that itchiness and to dry it. So all casts, we do neurovascular check, okay? Check every 15 minutes the first hour, then every hour for the next 24 hours. And then, because we want to make sure we didn't decrease blood flow to this extremity. Very important, okay? So sometimes we may need to take off the cast. Well, at one point, you may need to take off the cast. So some nursing intervention with that in teaching, because sometimes it's very scary. Somebody's coming at you with a saw to let them know it's not going to cut you. It's not going to hurt. All right, traction is our next topic. So with traction, there's skin and there's skeletal traction, and there's different types of traction, and it depends on the extremity, okay, you're trying to put back together. So if somebody has a fracture, you need traction, you need one pull this way, and you need counter traction, one pull the other way in order to fuse bone back together. Okay, you have to have traction and you have to have counter traction. So a little picture earlier on here are the different types of traction. It gives you a visual, Russell's versus Buck's traction, okay, versus spine. So depending on where the fracture happens will depend on the traction you use. So for example, Bryant's traction are used for your legs, your lower extremity, whereas Dunlap is used for the forearm. So which area are you working on? So in addition to that, NCLEX question with Bryant's traction deals with, let me show you Bryant's. So Bryant's traction is this picture right here, the second one going down on the left side. Okay, you see it says Bryant's traction. This is the one that's pulling the child's leg up and the child's body weight is pulling down. So Bryant's traction has a special NCLEX question. With Bryant's traction, remember earlier I said you need traction and you need counter traction to put bone back together. So with Bryant's traction, you need to make sure that that child's buttocks does not touch the bed. So buttocks are kept one hand level off the bed. You need to literally be able to slip your hand underneath this child's butt, because if the child's butt is ever touching the bed, you don't have counter traction. Okay, so this is this question where you walk into the room, when should you intervene? Yeah, and also with traction, the weight, because the weight is pulling to pull that bone together. If the weight ever touches the floor, you don't have counter traction. So that's the big deal with traction. You need counter traction when you're dealing with traction. Okay, so some nursing intervention, neurovascular check. Right? Neurovascular check, 15 minutes for the first 4 hours, so 15 minutes times 4, and then every 30 minutes times 2, and then every hour times 4. Like, you're always assessing this client and doing neurovascular check. Okay, automatically. Of course, skin is obviously a concern, and if it's major surgery where you're using where it's skeletal traction, pins and everything going through the skin and the bones, there's so many risk factors with this. You risk pulmonary emboli, you risk deep vein thrombus. Okay, so you want to make sure that you're assessing all of that. And here's little mnemonics for you for traction. If they help, beautiful, use them. If you have your own, that's fine. Okay. We talked about consent. All right, signing up consent forms and post-op teaching should be done before any pre-op medication. So you don't want to drug up the patient, then do your consent and teaching. No, no, no. Consent, teaching, then drugs. Okay? Because once you drug them, they're not awake, alert, oriented. Okay? So when they're signing that consent, they need to be awake, alert, oriented. So please don't reverse this one. That's an NCLEX question. Sign the consent, teaching, then drugs. Okay. So some little things I want to point out with pre-op procedures, some teaching we as nurses need to do. Okay, so pre-op, what's happening pre-op is a lot of teaching, is a lot of getting the consent signed, making sure Mrs. Jones knows what's going to be done to her, if she needs to empty her bladder, if we need to put a indwelling urinary catheter, if they have dentures, we remove it, we want to mark the site. All these little things are all pre-op things that we do. Okay, intra is during the procedure. Okay, so right in the middle of this procedure, we want to make sure we're maintaining asepsis. We want to make sure we do a timeout. Okay, we're going to cut the right leg type of thing. Post-op, we have a little mnemonic for you. For post-op, MMPPSS, right? So post-op care is very important. Priorities to maintain that airway. Okay, as a matter of fact, we don't transition you, okay, outside of the post-operative section to med-surg or to back wherever. Sometimes we're sending you home, it doesn't matter. You're not able to even be transitioned to the next phase, back to med-surg, wherever, until these are maintained. I can't send you off to a less, acute floor if your airway is not maintained, if your respiratory status, your cardiac rhythm, your pain is not managed, forget it. So your post-op care, these little mnemonics are great before you send the patient back to where they're coming from, or if you're discharging them. Okay, you cannot be discharged if your gag reflex isn't back, if your vitals are not stable, if you're not able to urinate, right? Crazy little things. So please take a look at those. Very common sense. So again, in order for you to be transferred back to med-surg, if that's where you're coming from, there are some things that need to be done. Okay. Some other post-operative care, I want to teach you how to use your incentive spirometer. If you've had surgery, that is a major thing I need to have done pre-op. And now post-op, we're actually doing it. I need you to cough and deep breathe and use that incentive spirometer because I want to prevent that pneumonia. Okay. You don't do that, then the patient is at risk for pneumonia. If there's dressing changes, if they need to learn their ADLs again, things like that. So there's a lot of management that needs to happen before we can transition you. Okay, depending on the procedure that was taking place, there's some complications you could expect. Okay, pneumonia is one of them, hence why we do the incentive spirometer. Okay, paralytic ileus. For example, I had the friend who had the jejunostomy. She ended up with paralytic ileus. So she had decreased bowels. They would give her feeding, it wouldn't go anywhere. So the physician had to go back and fix that. Sometimes it's from that damage of the lining of the tissue that causes that. But we cannot let you go on to the next unit or back to your floor with paralytic ileus, okay? So there are some things you need to monitor and assess post these procedures, a lot of complications, okay? So urinary retention is another one, imbalanced fluid and electrolytes, wound complication. So there's a lot of things we need to look out for, okay? We're almost done, hang in there. Radiation therapy. So radiation therapy, you need to remember, so you have Mrs. Jones has been diagnosed with breast cancer and may need radiation, right? So what type of radiation, what's the half-life of the radiation, but it's how you care for these clients. Clients on radiation, you need to be cautious of their body's secretion. Okay, so you cannot touch it. You need to make sure that you don't spend too much time even in these clients' room that are under radiation. And if they have, for example, an implant and it gets dislodged, you need to make sure you never touch that. There should be in their room a metal basin where you pick up that radium implant and you put it in there with the forceps. You can't touch them. And then past picking it up and putting it in the basin, you're done. We're not trained to handle this further. You need to call the radiation department. Our training is pretty much double glove, pick it up with the forceps, put it in the metal basin and call radiation. Beyond that, we're not trained to do that, okay? So for nursing intervention for radiation, the other thing too, you don't want to spend too much time in this client's room. You don't want to touch their body fluid. You want to flush the toilet twice. In addition to that, teach them to avoid washing off the spot for the radiation.